So I'm very pleased to be here. This is a longer, hopefully somewhat better thought through version of the talk that I gave yesterday, where I was the real beneficiary. I'm not thanking them at the end, so I'll thank them now. I got a lot of feedback yesterday, lots of long conversations after the ASI as well, and anyone who gave me any feedback at all, I really appreciate it, because I'm hoping it's starting to inform the spirit now of how I'm going to present this today. My presentation is situated mind, situated brain, and an active perspective, or maybe it's a fourth wave perspective, I'm not quite sure. It's some kind of perspective on disordered experience. And I want to acknowledge my co-authors here. First, there we go. The associated paper and the presentation was constructed in collaboration with my colleague at Concordia University, Professor Norman Segalowitz, as well as two of our graduate students, Jia Chang and Anastasia Voloshin. So the perspective I come from, as Lawrence mentioned at the beginning, is cultural clinical psychology. And with some colleagues, I've tried to play a role in helping this field cohere as a field. You can trace important papers and studies in cultural clinical psychology back to the very least, at least the 1970s, maybe even further back. But in the last dozen years or so, a group of us have been trying to consolidate these papers and theories and observations and so on into a coherent perspective. One that we hope would inform the practice of research, but also clinical practice in psychology. And for psychologists, what's particularly important is evaluation of patients. This would be assessment and diagnosis, and then of course intervention, especially psychotherapy. Cultural clinical psychology emerges from attempts to combine cultural psychology, which has long had an interest in the relation between culture and mind, and of course clinical psychology, which is increasingly becoming a discipline of mind and brain. Like cultural psychiatry, with which it's in constant dialogue and in a sense is a part of cultural psychiatry, cultural clinical psychology takes a systems approach and emphasizes feedback loops. In my view, cultural clinical psychology has already been successfully applied in my research group, as well as by others, to emotional disorders, especially anxiety and depression. And there are also examples of successful research programs, psychosis and personality disorders, somatoform disorders, and so on. So our guiding questions as we worked over the past several months on the discussion paper for the ASI and then on the talk are as follows. So the first guiding question is really a concern I've had for several years now, which is if I'm working in cultural clinical psychology or I'm collaborating with cultural psychiatry, we get very excited by how culture and mind and brain are all important. Not only are they important, but they are, in a sense, they constitute one another. They are maybe even different levels of the same system. And yet, what we do is we apply this sort of open-ended, interactive perspective to something that we call mental disorders. And as soon as I say mental disorders, from this perspective, I start to get worried that what we've done is smuggle the mind-body dualism that we've been trying to avoid reappears, because we're declaring that something mental is our subject area. So then that has led me to wonder whether there are other conditions that might be worth thinking about in a cultural clinical psychology or a cultural psychiatry kind of way. So in particular, the topic of this talk is what about brain disorders? I think there are some other disorders that we could consider as well, but we're taking today the focus on brain disorders, fitting with the theme of the situated brain. Then the third guiding question, and this is a more practical and applied question that's sort of the back of my mind, is would it be possible to imagine a cultural clinical neuropsychology. And for me, this question is driven by one of my graduate students, Jia Chang, who has as a career goal to be what maybe will be the first ever cultural clinical neuropsychologist. And we have had long discussions about whether the role of such a person is simply going to be to offer some minor cultural sensitivity trainings to neuropsychologists, or maybe renorm a test, or is there something deeper and more profound about the practice of neuropsychology that would be informed by a cultural clinical approach? So, mutual constitution is a core idea of cultural psychology, as I mentioned before. And there's this essential idea that culture and mind make each other up. And so this is the idea of Richard Schwader, going back 30 plus years now. This idea of culture and mind, sometimes it's culture and self or culture and psyche, that they make each other up. It's not just you need to pay attention to both of them, but it's that you cannot make sense of one without reference to the other. You shouldn't reduce one to the other. You have to consider them holistically. Schwader was a psychological anthropologist, and he proposed that cultural psychology, a little different from where we've ended up, he proposed this interdisciplinary meeting space of cultural psychology, where the psychological anthropologists would finally talk to the cross-cultural psychologists. Now the problem with mutual constitution, for me, the problem is not the idea itself, which I continue to find quite inspiring even, but it's that there's a tendency in my field to declare it. You say, well, I'm a cultural psychologist, I believe in the mutual constitution of culture and mind. I'm not like those cross-cultural psychologists who don't. And then we proceed to do research that's not that much different from cross-cultural psychology. So I think there are some questions about how we're understanding mutual constitution, and then how we're using it to design a research program that actually gets us places. I think there are examples of people who are doing this better these days, but it's still a problem for the field in my view, including with my own work. So, enactivist cognitive science, whatever wave you want to call it, offers, I think at its best, it offers a non-dual ontology that might help us to maybe break free more convincingly from some of the problems that certainly plague my field, cultural psychology. In the enactivists, the embodied, the 4E perspective, there's a lot of talk of continuities between mind and life, between self and world, and so on. And so it has struck me, and I've come across 4E cognitive science quite recently, right? So it was a bit of a revelation for me. I'd sort of caught the edges of it. But my engagement with it in a serious way has only been over the last year or so. But some of these writers are essentially implying that we could understand culture, mind, and brain as separate levels of a single system. And this idea really struck me when I finally read Sanneke Dehaan's book, Enactive Psychiatry, which I read kind of in one gigantic enthusiastic gulp in the late summer of last year. And then I was so excited by it that I ended up forming a little reading group of psychologists and philosophers to talk about it. Enactive Psychiatry is itself, of course, as you'd guess from the title, it's grounded in this same enactive cognitive science. And Dehaan in the book makes the central claim that the reason to be interested in psychiatric disorders and maybe to categorize them separately and to have a class of people who are really good at thinking about them and working with them and so on, is that psychiatric disorders stand out as disorders of sense-making. And the idea of sense-making as a kind of an essential human function is something that pervades enactive cognitive science. And important for my use of Dehaan, she identifies 4 dimensions that are essential to psychiatry. And in my paper and in this talk, I've renamed this aspects. And that's the reason to go from dimensions to aspects is simply a kind of psychologist's preference, that we tend in our field to have this quite specific meaning. Something's called a dimension, it has particular properties that I don't think DeHaan's dimensions have. So I'm going to say aspects, she says dimensions. I don't think that's that big a deal. Okay, so several allied disciplines have described this mutual constitution of culture, mind, and brain. It's not a cultural psychology specific idea. You can see elements of it in anthropology, for example. But one of the consequences is that enactive psychiatry and cultural psychiatry, I think that they combine very well. I think there's a reason why people in the cultural psychiatry interdisciplinary group have gotten quite intrigued by 4E cognitive science, by DeHaan's book, and so on. So that got us thinking about the scope of what you might call, in the interdisciplinary sense, enactive cultural psychiatry. Or, framed another way, what might cultural clinical psychology look like if it was thoroughly imbued with an enactive perspective, not just occasionally cited, but people were to really engage with it in a sustained way. What would that mean? The figure on the right, the idea there is simply to show that that DeHaan's aspects map very well onto this division into culture, mind, and brain levels of a single system. So in thinking about the scope, the future scope of enactive cultural psychiatry, or this sort of reconsidered cultural clinical psychology, got very interested in brain conditions and neurological conditions. And part of the reason for this is because, well, first of all, we had to prepare for a conference called The Situated Brain. And second, we were working with graduate students who were very interested in neuropsychology. And we had DeHaan's book that actually makes a pretty clear statement that you want to make a separation between psychiatric conditions and neurological conditions. She argues that an enactive account of psychiatry is possible because psychiatric disorders are disorders of sense-making. She makes the point, I think quite reasonably, that other disorders, like somatic disorders, most of them are not disorders of sense-making. But as she acknowledges, it gets particularly tricky with neurological conditions. She points out that they do indeed impact sense-making, but argues that their impact is secondary, that this is a secondary impact on sense-making rather than a primary impact on sense-making. And we wanted to push back against that a little bit. So should neurological conditions count? Well, it's easy to imagine a number of conditions treated by neurologists that we might not want to have count for what our field is going to do. So anything where you primarily need the neurosurgeon to go in and remove the threatening tumor, let's say, that is otherwise not affecting your sort of phenomenological experience in some way. Like maybe we don't need to count those. But we started thinking about some other neurological conditions and wondering, like, how clear is this line? First problem is it's not very obvious. It's not obvious to me, certainly, how to determine whether an impact on sense making is primary or secondary. It's not clear to me why you want to go to the trouble of doing so. I wonder what it is that it buys you to go through the effort to make that distinction. And remember, it's a distinction that you don't just have to make sort of conceptually. You might end up having to make it in terms of how you organize your clinic or what you're going to do with a particular client. Now, one argument is that when you look at neurological conditions, there's not a lot of evidence for, say, the impact of personal experience or the sociocultural context. There's some, I would argue. There's not a lot. But one concern is that if you already have a disciplinary history that says that this is neurological and this is psychiatric, the neurological conditions, because they're already being defined as brain-based, may not attract the same kind of research as psychiatric conditions would on the impact of personal experience, on social context, and so on. And our third concern is that there are real issues, I think, with using the absence of a biophysiological cause as a criterion. So at one point in her argument, DeHaan says that if we were to discover that a psychiatric disorder has a biophysiological cause, like a clear cause or substrate, I think is the word that she uses, that discovery would be the discovery that the disorder had all along been a neurological condition and not a psychiatric one. And the problem I have with that, and I think it comes from my prior experience doing work on somatization and interest in functional somatic syndromes and so on. I have a sense that that field got itself into trouble at various points by defining the syndromes they were interested in as those syndromes for which there's no physiological evidence. And it sort of creates this quest, if we can find the physiological evidence, then we can then get uninterested in whatever is going on psychologically or socially. I don't think that's the best way of doing things. And in fact, I would say that even if you find a clear physiological cause, you wouldn't necessarily want to give up right away on understanding other aspects of what's going on. It may actually still be critically important. We're going to get into that in a few minutes. So our current project was simply to explore these ideas, but through a consideration of the relevant literatures on three disorders with clear neurological implications. And I say disorders with clear neurological implications because the first one, schizophrenia, of course, is officially categorized as a psychiatric disorder. But it has, I would say, clear neurological implications. It's often first on people's lists in the argument for why neurology and psychiatry should just merge already and get it over with. There are not only functional brain consequences of schizophrenia, there are also structural evidence that something's going on in the brain when people have schizophrenia. But then we thought, okay, well, that's a good starting point, because there's also a really nice cultural psychiatry literature on social context and schizophrenia and so on. So there's our starting point. Now we're going to push over the frontier, the historical disciplinary frontier, and consider migraine headache, for which there's actually quite a lot of evidence for comorbidity with mood disorders, especially depression, even shared genetic heritability with psychiatric disorders and so on. But it's a disorder that neurologists traditionally would see, at least North American neurologists. And then finally we push even further to the case of dementia. So what I find interesting about these three conditions and other neurological conditions is you can certainly tell a coherent biophysiological story about them. And I think it's easier to tell a biophysiological story about these conditions than it is about, say, social anxiety or something like that. Schizophrenia has structural, these are just examples, but there's evidence in schizophrenia of increased cerebral ventricles. There's a prominent theory in migraine that there is an overloaded hypothalamus that is being overloaded by signals from other parts of the brain, and then this causes sort of nerve effects in the trigeminal area, and this causes headaches and so on. There's Alzheimer's disease with its characteristic plaques and tangles, often evident in autopsy studies after people have passed away from dementia. So certainly no one's arguing that these disorders have nothing to do with the brain. I'm certainly not arguing that. But what we started to find as we read deeper into this literature is that you could also preserve these biophysiological discoveries in what we think is a more comprehensive story that is a feedback loop story. That each of these conditions is also consistent with a feedback loop story, which I think is an enactive alternative. This story includes aspects that go beyond the biophysiological, or certainly incorporate the biophysiological. And again, 3 brief examples just to get you thinking about this. In schizophrenia, anyone who knows the cultural psychiatry literature will know all about this long research tradition on expressed emotion, particular ways in which people in the family communicate with the patient who has schizophrenia, particularly sort of high affect, judgmental, critical in various ways. And that's a particularly strong effect when it takes place in cultural contexts in which that's not the usual way of communicating. So there's some kind of family communication. It's experienced as a deviation from the sort of cultural consensus on normal communication, and so on. It's complicated because there are looping effects here as well, in that people who have schizophrenia often attract from their families more critical communication. The point is that what's going on in the family and in the larger culture is implicated in the story of schizophrenia. Second example from schizophrenia is social defeat, especially chronic social defeat. There's a growing European literature, been around for about 20 years now, showing that especially the children of migrants, especially when they're racialized, especially if they're lower SES, can be at particularly high risk for schizophrenia. So you get these high rates of schizophrenia in certain migrant communities, but you don't find those high rates if you go to the countries of origin and do epidemiological studies there. In migraine headache, there's quite a lot of work now on the effects of stress. This can be stress about goals and dreams that are being unrealized. You're being thwarted in your ambitions. Your life is not going the way that you wish it was. It's going actually in quite a different direction. You're impaired. People in your life, caregivers and family members and close friends and so on, are trying to help you, but they're also getting frustrated because you can't do things that other people can do. And the very fact of that stress seems to be implicated in worse migraines, more frequent migraines, and so on, which can create a feedback loop of headache and of stress. And then this stress plays out in relationships. Marriages end because of migraines, and then the person has more migraines, and so on. Finally, there's the example of cognitive reserve in dementia. So something actually I only learned this a few years ago. In dementia, especially in Alzheimer's disease, there are all sorts of examples of people who at the sort of neuroanatomical level, in terms of plaques and tangles, have their brains look like the brains of Alzheimer's patients. And yet, they are functioning well, and not just well because everyone around them is bailing them out and helping them. They really are they're just functioning well. Their memories are good, their social relationships are good, and then you look at the brain and you think, my goodness. In some cases, a blow happens to them, and often it's a blow to their interpersonal network. Classic example would be bereavement. Something gets disrupted in the network, and the person rapidly develops dementia. But you look at the brain, it's the neurologist is concluding, well, actually, the brain has had this going on for quite a while. A slow development of plaques and tangles, but quite a rapid shift in terms of mental status. Reasons for this, but one of them is to do with the role of familiar environments, caregivers, good relationships, and other things that help to, in a way, the person might be even outsourcing some of their cognitive abilities through their social network and into their physical environment. So we started thinking maybe some neurological conditions should count. Okay, should count. We don't want to privilege the psychiatry-neurology distinction just because it already exists. And Tahan, actually, I think she shows us a potential way out when she talks about severity. She says, these problems have to be severe enough to be worth attending to if you're a psychiatrist, for example. But you can understand that dimensionally, and the cutoff is going to be somewhat pragmatic, not arbitrary exactly, but we're not carving nature at the joints. There's a point at which this is severe enough that we might want to really pay attention to it. We are proposing that loopiness, in quotes right now, I'm not sure if that's the best term, should also be understood dimensionally with a conventional threshold, that disorders may be more or less prone to these feedback loops, and not just any feedback loops, but feedback loops that cut through the biophysiological, experiential, sociocultural, and existential aspects of the human experience. And we've tried to represent this in a figure where we have this dimension of increasing loopiness from left to right. And on the left we have a story. This would be a condition or a patient for whom the biophysiological story does most of the work, maybe does all of the work. The other aspects are relevant, they're interesting, but the biophysiological story isn't really changed by them, right? So someone has a tumor, it's still worth looking at family caregivers or what it's like for them existentially to contemplate having a tumor in their brain, but their existential contemplations don't change the size of the tumor. The biophysiological story tells itself. Then there is these other aspects that might be worth paying attention to as well. The more to the right you go, the more you get to conditions in which what you think of yourself for having the condition, how your social world reacts to you having it, and so on, is implicated in the sort of the nature of the condition itself. It becomes a different thing precisely because of how the people who have it think about it and the people around them talk about it. Why loops? Well, the thing is, you can't just say that we're interested in disorders that involve the four aspects. Every condition involves these four aspects. And many of these conditions interfere with sense-making in some way. But only in some cases are the loops transformative. Do we have to focus on them? Because if we don't, we just don't understand at all the problem that we're dealing with. So why bother? Anyway, I wish that this window wasn't here because it's hiding the fact that this painting is called The Escape from Criticism. We're going to try to apologize just a little bit. So psychiatry and neurology have long histories. They've traded disorders back and forth. They're different in different countries. Like, it can stay the way it is as far as I'm concerned. It doesn't really matter. And also, this is not about nitpicking the 3 pages of Dehaan that we did not entirely like. I loved this book. I thought these were the 3 weakest pages. I don't want to be the kind of person who then says, okay, I'm going to do a whole paper and presentation about these 3 pages. But I do think that there might be a better way of thinking about it that would actually be largely consistent with her project. Finally, and I say this a bit more tentatively, I hope this is not about sneaking mind-body dualism in through the back door, but it's always easy to get ensnared by that. And so I think that would be, I'd be open to hearing about ways in which I could push even further towards avoiding doing that. Okay, fine. So that's what I'm not doing. That's what we're not doing. So what are we doing? Well, first of all, this is divided into psychology's classic division into psychopathology, assessment, and treatment. We want to conceptualize problems that concern us in ways that point to further understanding. We want to evaluate problems at the level of the individual person in context. We might not just put disorders on this continuum, but individual people might move across it, just like they move across the continuum of severity. And finally, we want to intervene in problems through multiple sites of intervention and their cascading implications. If you see certain disorders this way, you might treat them differently. You might remember the social world, you might remember how the person feels about it, not just because it's relevant to, say, good bedside manner, but because you will not be addressing the problem unless you address it all. And these are the questions I will leave you with. Might this perspective become as useful to understanding at least some neurological conditions as it is for psychiatric conditions? Will it help to break down the divide between psychiatry and neurology, but not through the sort of the neuroreductionist solution? Could we extend this to other somatic disorders, such as the disorders that are implicated in psychoneuroimmunology? And will this promote renewed attention to the social context in which caregiving and treatment take place? I'll end by thanking my non-co-author interlocutors who've helped me think through a lot of these ideas. And I'll thank you very much for your attention.